Right, we've had some time out reflecting on what we feel families who come into contact with health and social care services expect of health and social care organisations when the outcome of care and treatment is less than was hoped for. And I'm interested to know what you think might be some of the issues that as professionals, but also as ordinary people in our personal lives, we may be mums and dads, we may be sisters, brothers, nephews, what we expect if we were on the other side of the fence. So I'd like to just come around the room and ask a range of questions and just to see what you came out with in your group discussions. Tim, could I start with yourself or whoever is the agreed spokesperson for your table in terms of what you think is expected of us from health and social care when things go wrong or seem to go wrong, and what your thoughts were about involving patients, families and service users.
Did you want to speak?
Well, we felt that families would feel it most important that they had honesty, empathy and acknowledgement of their situation in our interactions with them, and that they would want to know that we would learn from what happened and it wouldn't happen again.
Okay, and do you think that the expectation that it won't happen again is a realistic expectation?
I think this is where we need to manage expectations and share a realistic point of view with them on what we can fix and what may be unfixable.
Excellent, yes, and I would be inclined to agree with that because I think this can be a big challenge for families, that they want a reassurance that it won't happen again, but when we're conducting reviews, in spite of our best efforts, we know that we can't eradicate the problem, particularly if the issue is a human behaviour orientated issue, or that the whole care process relies very much on what I would call human control measures. So they are subject and vulnerable to variability just because as human beings we're subject to variability in our everyday lives. So thank you for that, it's a very useful contribution. Bryony, for your group, or anybody on your table.
Something that we were discussing as well about involving the families with the investigations, and actually a few of us found that we didn't involve them in the investigation process, where Bryony had experience where she asked them the families questions initially about an incident that had occurred, did the investigation, had her own questions, then answered the questions for the relatives in her report as well. Whereas experience, we were feeding back to relatives after the investigation for what the investigation had found, not including them in the initial part of the investigation process.
Okay, and in the context of the discussion we're having right now, is there any sense that that approach of feeding back, because I think it's a very powerful, very good thing to do, to feed back what we've learned from the conduct of an adverse event review, how would it feel, do you think, in terms of if I suggested that you should have a proactive meeting with the family early on in the process to find out what it is they would like from the review process or the investigation?
I think, depending on what the incident is and how emotive it is, then the proactive thing, there could be a lot of, I suppose these would be better in the majority of cases because you are being open, you are explaining that you're investigating something, and you're making them aware of what, obviously you don't know what the findings are at that point, but get their opinion on the care, level of care that they have.
And it gives them a stake in the process. And the questions that a family might have may be questions that you've already thought of. My experience is quite often families ask very sensible, very reasonable questions that an effective investigator will have already thought of if they've got the patient and the family at the heart of the investigation process. Because it's a very natural thing as a reviewer to think, if this were my family, if this were my mum, if this were my dad or my brother or sister, what questions would I have about the case management? And it's also one of the big issues about involving somebody on an investigation team who is non-clinical or completely from outside of the service that has experienced the review, because there's a much greater chance of those questions emerging just because you're coming from a less experienced viewpoint. So again, thank you very much, very helpful. Mark, Sharon, for your group. Anything that you'd like to add to what's coming out from around the room?
In terms of the what do you think the public expects, we second what the other group said, but we also said that sometimes families want retribution and some form of recompense. They want to know if the person responsible for an act has been taken through a HR process, or they've been, they want them sacked, and it's about us as the investigators managing that expectation and sharing with them a level of information that is appropriate for them to have, but without breaching the confidentiality of the staff that are going through the investigation process, but being open and honest so they don't think that we're withholding information from them or whitewashing the whole incident. So that's quite a challenging element of that first point, I think.
And I would be inclined to agree with that. And if you're a family and you're hurting because a loved one has suffered, then anger is a natural consequence of that. And to want to see, if you think staff were responsible, to want to see that managed appropriately, I think is understandable. And I've certainly been in a situation where a family, that's what the family wanted, and particularly if the family come from a related agency, for example, like the police force, where a disciplinary culture, and the ambulance services actually, where a disciplinary culture is far more embedded. They find it very difficult to understand how in health and social care, where we're taking a much more systems-oriented approach, but why they see staff, or why staff appear not to be being disciplined for incidents where they would be disciplined within their own service. That can be very, very challenging to manage. And again, to be able to talk a family through the investigation process and how it's done, and in fact to use things like the incident decision tree so they can understand how we're going about the work we do, I think is very important in it being an open and inclusive process. Claire, can I just ask you, is there anything different going on in Wales?
No, I think that what the other tables have talked about and what Sharon's talked about is pretty much what is happening really in our area.
Yeah. So the same sort of drive to having a kind of a more transparent approach to the whole of the investigation process and engaging families where possible.
Yeah.
Lovely, thank you. And Elizabeth, may I come to your table?
I've had limited experience going to feedback to families, and that's been feeding back within the family's home and feeding back within a hospital setting. And I think you need to be mindful of that setting. And also to be mindful of what the patient's pathway is going to be, because if they're still within the system, they're often very anxious that any complaint they may be seen to have made may affect their future care, and I think they want reassurance that that isn't going to be the case. And also, if they've still got further surgery to have, that what has happened on them on the first surgery is not going to happen to them on the second surgery. And yet, for that angle, they do want the reassurance that everybody does know that something has happened to them before, just to make sure that that couldn't possibly happen to them again.
Yeah, and I think that's, again, a very helpful reflection about the complexities of managing an adverse incident, openness, transparency, when the patient or the service user or the client, if it's a social care case, is actually still actively in receipt of services. That does bring a layer of complexity, and I think I've certainly heard many times about families being worried about making a complaint or raising a concern because they don't want their care compromised in the future. Sharon.
We debated quite a lot about how much should you tell and how do you gauge that as being in the best interests of somebody. Although people say they want you to be open and honest, and we talk about transparency, sometimes that can be harmful.
Yes.
So we debated that. We didn't come to a conclusion, unfortunately. The other thing is about patient confidentiality. So, a lot of these incidents, the patients doesn't die as a result. So how much should you be telling family when they're asking questions? And if an event happens and a family member, a grandparent or whatever starts to ask questions, how open can you be, and how do you drill down into what information you can give or should give?
I think that is a very useful contribution. One of the things I would suggest, particularly if you're an adverse event reviewer, you're conducting investigations and the patient can be a participant and you can go to them and ask them. If you anticipate that family members are going to show an interest and are going to want to have an involvement, it's worth being very proactive and talking that through with the patient or service user at a very early stage, and seeking their permission to share information and getting them to sign a consent form, just a data release consent form. But again, as family members come forward, because consent is a living thing, if there's weeks between, for example, each inquiry, you should probably generally keep going, if the patient's well enough, keep going back to the patient, or invite the family in for a meeting with the patient if that works, so that makes it comfortable for everybody and everybody's in the same space hearing the same information real time, which avoids third-party misinterpretation of information shared. Lorraine, I'd like to ask you, because you're a layperson in the room, you don't have a health or social care background, and you're representing the other lay people in the room. What sorts of things did you come up with in terms of, as non-professionals, in terms of health and social care, about what your expectations are of us when we do reviews?
Okay, so and it's very much in line with what the professionals have said anyway. So they're looking that you find out the answers of the questions, so you're who, why, what, where, when and how, of what went wrong, and that you're going to learn from that. That the professionals are being as honest as they can in the dealings with the family, and the possible, like you're saying, managing the expectations as well. The report needs to be quite clear and succinct, with minimal jargon and clear English, so it's easy to navigate when the report finally comes out. Otherwise it's quite difficult to follow. Meeting with the family face to face rather than just through a report before the report comes out. And that it'll come out in a timely manner, so that there's an expectation of when that report's going to be published, for example. So there's an expected time frame there. And knowing that the lessons will be learned, but as you've already mentioned, that's not always possible, but that's what I think the lay people are after. When is that lesson going to be learned? Is it going to be learned? What are you going to do with the information? Or is the report just going to sit on a shelf?
That's very helpful, and that in fact resonates with everything that we've reflected as professionals, and that's what I expected to happen. Now, one question I have got, and I am going to pose it to you, Lorraine, if you don't mind, is about managing the unknowns that I don't know. So sometimes when we do reviews, we don't always have answers to questions, and I've certainly worked with in scenarios where that causes quite a lot of anxiety. As a layperson, do you think it's acceptable for an organisation or an investigation team or lead to say, we have tried to explore this, but actually we can't give you an answer to your question because we simply do not know?
Absolutely. It's much better to be told that honestly than raising false expectations, I think.
Okay, I think that I'm hoping that actually is a helpful answer for people in the room, because I've certainly looked at reports where the I don't know bit is fudged in an investigation report, because as professionals it does feel uncomfortable to say we don't know. And it's a bit like finding root causes to problems and incidents where actually we don't know what the root causes are. It's much better to say we've identified weak areas or risk opportunity points within the system, but on this occasion we don't know how the error occurred. We just don't know, and we've looked at all of these things, but we still don't know. I think that is received much more honestly. And the other issue that I have picked up from families is answer the question. don't just say sorry. There is little value to a family in saying, I'm terribly sorry you had this experience, I'm terribly sorry. If their question actually can have an explanation or an answer, it may be that they've misunderstood. So an example would be a family on ITU where perhaps life enhancing or life continuing treatment is withdrawn, and the family then have concerns because the endotracheal tube is left in situ, and they think that the life of the patient has been unnecessarily prolonged when a decision has been made to withdraw treatment. I've certainly had an experience where I was with a dying patient and I turned the heart rate monitor off because I felt it was a kinder thing to do rather than the family watch the heart stop. The family thought I had hastened, that what I was doing was hastening the end of their loved one's life. Now, in that scenario, it was very real time and I turned the machine back on again. But these sorts of things sometimes are lack of understanding issues. So rather than just saying, I'm sorry, explain the process. One of the things I've learned over the years is you may not be able to answer questions as to why something happened, but 9 times out of 10 you can explain the process and how it works, and why what looked to them to be something that was done wrong or badly actually is how a procedure might be done and how any unit anywhere in the country might do it. So I think these are important nuances to be aware of. If you're in the business of conducting reviews, meeting families and feeding back the findings, conclusions and recommendations of reports, do make sure you go with somebody else. Don't go on your own. You should always have a colleague with you. It's not professionally safe to go on your own. Otherwise, nobody has an objective perspective about that meeting, particularly if the family are not happy with that meeting afterwards. They generally will always be supported. The other thing is to be mindful that a family will be hurting, and how you come across to them, your demeanour, your attitude will leave a lasting impression. I've certainly worked with families who are angry to this day, not about the incident. They've been able to move on from that. They're angry about the attitude and the seeming closed attitude of the professionals that came to share the findings, conclusions and recommendations of the report. Any good that's been done from the investigation is undone if we come across as insensitive when we meet families. And I guess that would be the last thing that I would have to say on that.